my name is Christina. I am Associate Professor on the Department of Internal Medicine, Orenburg State Medical University, and I am going to presenting a lecture on topic nephrotic syndrome. We will start from basics, what is definition, incidence, causes of nephrotic syndrome. We also recall about structure and function of kidneys and nephron in normal conditions, in pathology, and then also we will speak about pathogenesis, clinical science, diagnostic and treatment of nephrotic syndrome. Let's start from basics. What is nephrotic syndrome? It is clinical and laboratory symptom complex which includes proteinuria, hypoalbuminemia, hypoproteinemia, edema, hyperlipidemia, hypovolemia, hypocalcemia and hypercoagulation. Of them we have basic signs which are mandatory to be. They are proteinuria, which is more than 3.5 gram per day, and hypoproteinemia, less than 60 gram per liter, and edema is one more very typical signs. Other symptom signs are additional, and nephrotic syndrome, it is not a disease, it is syndrome. That means collection of symptoms which may be seen in different diseases. Incidence, why this topic is actual for us, is relevant for us. Nephrotic syndrome is, in one side it is relatively rare condition, in another side it is important because it is manifestation of many kidney diseases leading to final kidney failure. For example, incidence about 3 new cases per 100,000 each year in adults, and in childs, it's also high incidence, and in different countries it is different parameters. For example, nephrotic syndrome is more common in children in 15 times comparing with adults, and most cause of this in children is minimal change disease. In adults, the most common form is membranous glomerulonephritis and focal segmental glomerulosclerosis. Diabetic nephropathy is a cause in elderly category of patients which age is more than 65 years. And among causes, primary causes relapse very frequently. In different countries, we have different worldwide prevalence of nephrotic syndrome. In this scheme, you can see prevalence of nephrotic syndrome due to minimal change disease or minimal change lesions. This disease causes damage of nephrons and especially cells which called podocytes. That's why it is podocytopathy type. And you can see that prevalence depends on countries, and for example, for Indian, it is more important and relevant topic, for example, comparing with Russia. And you can see values 21, 30 specific units about per population. Another disease, focal segmental glomerulosclerosis, one more cause of nephrotic syndrome. And we also can see that incidence for India, for example, it is higher in comparison with many other countries. However, there are in other countries having more severe staining in schema and having more severe prevalence. How this data was calculated? They are expressed as a percentages to total kidney biopsy, and they were obtained from international registers. So, concluding, we can understand that topic is relevant for us. Etiology, causes of nephrotic syndrome. There are two large types of nephrotic syndrome, primary and secondary. Primary is more common, it is about 95%. It is being a disease specific to the kidney. Secondary is less common, about 15%, and it is being a renal manifestation of some another disease, of some systemic illness. Causes of primary nephrotic syndromes are following: minimal change disease nephropathy, mesangial proliferative glomerulonephritis or nephropathy, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis or membranous nephropathy, and other rare causes. Examples of secondary are following: first of all, infection, giving nephrotoxic medication, nephrotoxic effect like virus hepatitis B, hepatitis C, malaria, and so on. Then drugs having nephrotoxic effect, of them non-steroid anti-inflammatory drugs and some antibiotics maybe also, and penicillamine. Then systemic diseases in which kidney are damaged, like systemic lupus erythematosus. Malignancies can cause it also, leukemia, lymphoma, diabetes mellitus and its complication on kidney, and also amyloidosis and paraproteinemia. Let's revise structure of kidney in normal condition, in healthy situation. Kidney is comprised of functional units called nephrons. Each of these has glomerulus and tubule. In this scheme we can see kidney and its unit, which is nephron. And we have glomerulars, it is capsule, Bowman capsule, and we have some tubules, it is proximal convoluted tubules, and also we have vascular component, afferent near arteriole, it is coming inside to the glomerulars, then it is divided into the network of vessels, and then afferent arterioles in which blood coming next. Have a look on the picture, structure of nephron. We can see kidney have many units, they are nephrons. Its units structural, having glomerulars, capsular and tubules, proximal convoluted and other tubules. For us is particular interest of it is glomerular or capsular Bowman now. It has following structures. In transverse section we can see many vessels and many structures of kidney. These vessels are network from afferent arteriole. Afferent arteriole is coming to the kidney and then spreads to the network of small vessels, capillaries. Every capillary is filled with endothelial fenestrated cell. And then a network blood is collected and going away to afferent arteriole. Then in transverse section we can see podocytes. They are cells of nephron. Podocytes, it is cells having specific processes, and on scheme you can see numerous small processes here. They play important role for glomerular barrier. Then in this scheme we can also see epithelial cells, parietal epithelial cells which lining capsula, and between them there is space. In this space fluid from vessels filtrate inside in the space and coming to proximal convoluted tubules. If we see transverse section between endothelium of vessel and between this space there are processes of food, and there is basement membrane. It is small structure, basement membrane. And in longitudinal sections we can see that podocytes has many processes, and these processes connect each other. It is important for making filtration barrier. Let's continue, and in next picture we can see 3 layers of filtration or glomerular barrier. It is endothelial cells, endothelial layer. They have many fenestrae, that's why it is called fenestrated. Then it is basement membrane and podocytes forming epithelial layer. 3 structure. Basement membrane consists of a central electron-dense layer, lamina densa, and 2 adjacent layers. It acts as a semi-permeable filter, preventing the passage of macromolecules and allowing fluid and low molecular weight solutes. The passage of molecules with diameter of more than 4.5 nanometer is blocked in healthy situation, but in diseases, we will discuss it, it may be damaged and possible. Podocytes of the epithelial cells have important role in normal functioning of glomerular slit membrane. Its structure. In function, under normal condition, Several kinds of physical stress is present in glomerulars, and hydrostatic pressure gradient is act in vessel in this scheme, and it is act uniform in different podocytes, and this is equal action in different cells. Every podocyte food process has this pressure. Fluid filtration across the glomerulars generates shear stress of the lateral aspects of the food processes, and filtrate flow laterally across the podocyte cell body in the Bowman space confers shear stress. Podocytes derived vascular endothelial factor stimulate, it acts on intravascular endothelial cells and is important, it is need for maintaining glomerular filtration barrier and keeping serum protein like albumin be inside in vessel, inside the vasculation. These forces act so that albumin is inside in vessels, but fluid is coming to the capsule of Bowman glomerular. In pathology, what has happened in pathology? Main problem, it is podocytes which are damaged, absent, and we can see on the scheme that here is absent, podocyte which is absent, food process is absent, and we have specific high horizontal stress, and we have problem that albumin is coming from vessel to this space, and as albumin may catch other proteins, they are also coming through, as well as some electrolytes can go, and so on. And this is problem in filtration barrier. Barrier does not work properly, does not filter itself, and we have some manifestations which we will discuss soon. Pathogenesis of nephrotic syndrome. So, main problem in nephrotic syndrome, as we understood, is damage of glomerulars. Glomerulars damage may be with different ways. For example, membranous glomerulonephritis. In this situation, there are antibodies which attacked podocytes, thickening glomerular membrane appears. In minimal change disease, we have damage of podocytes on epithelial side of glomerulars, so-called podocyte effacement. In diabetes mellitus, there is chronic hyperglycemia which make damage of glomeruli. For focal segmental glomerulosclerosis, we have injury of glomerular endothelium, both endothelium and epithelium, scarring of nephrons. For secondary causes, for membranoproliferative glomerulonephritis, lupus, and in other causes, there are immune complex deposition into glomerulars. For amyloidosis, we have amyloid deposition into glomerulars, and all this finally leads to damaged glomerulars, abnormally permeable to proteins within the blood, and plasma proteins are thus excessively filtered out. Excessive filtered out, that means first of all albumin, which is filtered out, excessive loss of albumin in urine, and also loss of anticoagulant proteins. What outcome for loss of albumin? This condition is called hypoalbuminemia and hyperalbuminuria. Why it is problem? First of all, because we have calcium binding with albumins. 50% of serum calcium is albumin bound. So in this situation, we have decrease in total calcium level. Serum total calcium does not reflect ionized calcium, but actually it is decreased. Then one more outcome is the anion gap is mostly due to the negative charge of plasma albumin, decreasing anion gap. Then albumin level is low. This leads to decreased blood oncotic pressure, and it decreases and makes signal for liver to stimulate synthesis of albumin and another structures. Anabolic activity in liver is increases, lipoprotein synthesis is increases, and we can see hyperlipidemia. High serum low density lipoprotein, very low density lipoprotein, high triglyceride level, and so on. It is dangerous because it stimulates atherosclerosis development and all other manifestations which are associated with high lipids level. These lipids are filtered into renal tubules, end up in urine, and we can detect lipiduria. Lipiduria manifestate like presence of lipid or fatty casts in urine, sign under polarized light, Maltese cross sign, specific signs. Then blood pressure is, oncotic pressure is decreased in blood, and this leads to presence of edema. Ability of blood to retain fluids within vessels decreased, fluid leaks into extravascular space, and we have edema, so-called underfill type of edema, which may be local, like periorbital edema, classical signs, and in long time it may be generalized, anasarca. Let's have a look on proteinuria. Of course, it is sign because not single albumin lost, but different proteins, total proteinuria, which is very high. Second problem, it is when we have loss of anticoagulant proteins through the kidney, and we have following problem. Since counterbalancing anticoagulant proteins are lost, clotting factors now have more activity, and blood pressure, blood becomes more hypercoagulable, and this leads to complications like thromboembolism, deep vein thrombosis, pulmonary embolism, and so on. It's one complication due to this is scheme. Hypovolemia occurs secondly due to hypoalbuminemia, because oncotic pressure is decreases. It is resulting in a loss of plasma water into the interstitium and causing a decrease in circulating blood volume. But hypovolemia, it is usually late sign, which observed in albumin level, which is less 1.5 gram per deciliter. Hypotension usually seen in late stage, whereas in early stage it is hypertension preserved. Then hypocalcemia, we already discussed it. It is very common for nephrotic syndrome, but rather than being a true hypocalcemia. So false hypocalcemia develops firstly due to albumin decreased and binding of calcium is decreased. But secondary, if nephrotic syndrome lasts for long time, we have appearance of primary hypocalcemia. It is due to low bone density, abnormal bone histology as reported. It is outcome of hypocalcemia, and main causes it's vitamin D decreased due to its binding proteins, and it is also coming through urine away of the body. Hypovitaminosis D develops, and reduced interstitial absorption of calcium. It's also one more causes of development hypocalcemia. Next, hypercoagulation. It's multifactorial in origin. First of all, it's due to increased urinary loss of antithrombin 3. Then we have altered levels and increased activity of protein C, protein S. They matter for coagulation process. Then we have increased fibrinogenemia due to increased hepatic synthesis. We have impaired fibrinolysis due to decreased plasminogen, and we have also increased platelet aggregability, relative immobility in patient, hemoconcentration from hypovolemia, and finally hyperlipidemia also contributes to increased platelet aggregability. Finally, alteration in endothelial function. All these chains make one result, it is hypercoagulability of blood. Next, clinical symptom, very important clinical sign of nephrotic syndrome is edema. Edema, it is first place and it is early sign of nephrotic syndrome. First of all, it is detected in eyelids. It appears in the morning, and only till the evening it may appear in ankles or after ambulation. Edema usually focal, it is not generalized, it's initially focal and may be reason for seeking help for such complaints like difficulty breathing because patient has pleural effusion or laryngeal edema. Patient can have substernal chest pain due to pericardial effusion. He may have scrotal swelling, swollen knees, hydroarthrosis, Ascites, it is abdomen, swollen abdomen when fluid accumulates in abdominal cavity. It may be abdominal pain due to edema on the mesentery. And finally, it may be generalized in late and advanced stages anasarca. But the most important for us, periorbital edema, puffy pale face, swollen lips. On this picture you can see patient. On the right side, this girl was before treatment with nephrotic syndrome. In left picture she is after treatment, effective treatment of nephrotic syndrome. And you can see that it's very clear success of treatment. Prolonged nephrotic syndrome may result in nutritional deficiency, including protein malnutrition. Then patient can also develop myopathia, titania due to decreased calcium level, spontaneous peritonitis and frequent opportunistic infections, coagulation disorders as we already said, hypovolemia, thrombotic risk and hypertension. Development of nephrotic syndrome. There are three ways for development of nephrotic syndrome. It may be episodic nephrotic syndrome, persistent and progressive nephrotic syndrome. Episodic, observed at the beginning of underlying diseases, and it is usually outcome to remission or may be recurrent with relapses when we have relapses alternated with remission. Remission may be spontaneous, may be due to usage of some drug, but it is alternate and it is very favorable situation. Usually it is seen in minimal change diseases or at the beginning of more serious diseases. It's more often observed when kidney function is not impaired and for a long time it's remained to be normal. Then, second situation, persistent nephrotic syndrome. It's about 1/2 of patients. When nephrotic syndrome persists stubbornly for 5-8 years despite active treatment, active therapy. And this variant is more typical for such kind of glomerulonephritis like membranous, mesangiocapillary types, chronic glomerulonephritis. And usually during 10 years from onset of development, these patients gradually develops chronic kidney renal failure. And we have progressive and rapidly progressive option of nephrotic syndrome when we have 1-3 year and patient achieve end-stage kidney disease, kidney failure. It's very quickly, and you can see it occurs about in 1/3 of patients. It is observed usually in extracapillary types glomerulonephritis, focal segmental glomerular sclerosis. Types of nephrotic syndrome classification. It may be hypo and hypervolemic. Hypovolemic is accompanied by very low albumin level, less than 2 grams per liter. Also, it is accompanied with more than 50% of normal GFR, glomerular filtration rate. It is not arterial hypertension, it is hypotension present, and even orthostatic hypotension preserved. Whereas hypervolemic type usually develops in albumin level more than 2 grams per liter, GFR which is very decreased, less than 15% of normal range. Hypertension is very typical, and orthostatic hypotension usually it is not typical. Diagnostic of nephrotic syndrome. Our aim is to, first of all, verify nephrotic syndrome and recognize its cause for further treatment. We remember that it is not disease but syndrome, and causes are different. Usually, patient with edema is coming for our consultation, and edema is first sign to recognize, to suspect nephrotic syndrome. We prescribe urine analysis, we prescribe blood analysis, and if we see in urine analysis very high proteinuria, like 3-3.5 grams per liter, we will check selectivity of proteins. In blood level, we can see two situations. It may be normal, not changed, but it may be protein level is decreased. Anyway, we must check proteinogram, we must check coagulation and lipidogram. Proteinogram usually shows us decreased level in albumin, in alpha-2 globulin, and whereas fibrinogen is high. Coagulation shows us hypercoagulation, and lipidogram usually shows us hyperlipidemia in total cholesterol, LDH, low-density lipoprotein. They are high. Finally, we, having all these components, we conclude proteinuria present, hypoalbuminemia present, edema present, lipidemia, hyperlipidemia present. That means patient has nephrotic syndrome. We verified nephrotic syndrome. Second point, we must find cause. We use clinical data, we collect anamnesis, physical examination, information about possible and other diseases, and we can recognize cause of nephrotic syndrome, activity of disease. We must always check kidney function at this moment, presence of autoimmune diseases, and so on. And then we make final diagnosis, disease, firstly disease, and secondly nephrotic syndrome which manifestate, and give proper treatment. Laboratory finding for nephrotic syndrome. The following laboratory analyses help us to suspect this problem. If we're checking urine analysis, protein will be high, albumin will be high. When we check selectivity of urine protein, what does it mean? Proteinuria may be selective and non-selective. Selective means only low molecular weight proteins drop through kidney to urine, which is more favorable, whereas non-selective proteinuria shows significant damage to glomerular barrier. Then we usually can see fatty cast, they appears, or oval fat bodies appears. Then we must pay attention that hematuria, leukocyturia, bacteriuria are not typical for clear nephrotic syndrome. It might be seen in combination of nephrotic syndrome with any another pathology. Then, if we see glucosuria, presence of glucose in urine, this means uncompensated diabetes mellitus. If we see Benz-Jones proteins, that means patient develops paraproteinemia, multiple myeloma disease. Then we check laboratory analysis. Mostly it is CBC, complete blood count. It is without deviations. Sometimes we can see decreasing in level erythrocytes and hemoglobin. Mild anemia maybe develops as manifestation of some chronic disease, especially autoimmune disease, or especially if present hemolytic anemia may be also seen, and pancytopenia develops in lupus nephritis. Biochemical analysis. It is especially important for us because we can detect total protein is low, albumin is low. Sometimes urea, creatinine are increased because they shows kidney function, and kidney is impaired, is damaged, they are increased. Then glomerular filtration rate. It is increased in early stage when we have hyperfiltration compensatory mechanism, but then it is decreases showing kidney failure. Then vitamin D usually decreased. Then if patient have high glucose level, fasting glucose high, glycated hemoglobin high, that means diabetic cause of nephropathia. If paraprotein appears or cryoglobulin appears, that means disease paraproteinemia. Then we also do lipid profile, and as I said before, the most important parameter for us they are total cholesterol, low density lipoprotein, very low density lipoproteins, because they are increased. In coagulogram, we can see fibrinogen is increased, D-dimer is increased, antithrombin 3 is decreased, and plasminogen is decreased. Then, if required, we can do additionally immunological test. For example, we suspect some autoimmune disease. In lupus nephritis, C-reactive protein will be high. Immunoglobulins and other immunoglobulins, IgG and others, will be probably decreased, complement system will be decreased, and appearance of some antibodies, for example, anti-nuclear antibodies, anti-DNA, anti-SMID, anti-phospholipid antibodies, depend on what kind of disease is making damage on the kidney. And electrolytes checkup can help us to detect serum calcium level decreased, anion gap decreased, and maybe sodium increased. It was laboratory data. Now clinical findings, they are following. Edema, as I said before, it is usually mild, mobile, on the face, puffy eyelids, and so on. Then, if we see skin erythema, it may be typical for nephrotic crisis. It looks like migratory erythema erysipelas without precise location. It is migratory and usually accompanied by abdominal pain. It is signs of nephrotic crisis. If we see skin rash, it's usually sign for some systemic rheumatological diseases. For example, skin rash in decal area, typical for systemic lupus erythematosus. It may be in form of butterfly on the face, also typical for this. It may be seen in extremities and be sign of some kind of vasculitis. Then, if we see mucosal damage, enanthemas, cheilitis, stomatitis, it is also typical for systemic diseases. Articular syndrome, systemic diseases, it may be arthralgia without deformities, or it may be small joints of the hand involvement with deformity, symmetrical. In these cases, it is sign for rheumatoid arthritis. Rheumatoid arthritis usually complicated by amyloidosis, which is cause of nephrotic syndrome. Then, if we're checking expectoration from respiratory tract, we can see bloody expectoration from nose, bloody sputum. It is sign for systemic vasculitis. If we see decreased sensitivity of skin of patient, sensitivity especially in peripheral and extremities, in upper and lower lips, this sign mostly for diabetes mellitus, as well as orthostatic hypotension appearance. What is orthostatic hypotension? It is difference in blood pressure level between sitting and standing patient. Then we can detect enlarged lymph nodes in some areas, and this sign is very important and significant for verifying oncological diseases and subsequent paraneoplastic nephropathies. And instrumental diagnostics which used for confirming nephrotic syndrome. Of course, they are different, depend on cause, but we usually use ultrasonography and MRI for checking kidney structure, for detecting abnormalities, for finding deep vein thrombosis in lower extremities. We also do chest X-ray for checking presence edema, effusion, congestion in lungs, so it is absent. And in many situations, we do kidney biopsy. This is the most precise method for checking particular disease causing nephrotic syndrome. And after biopsy, we look this material, we watch it with light microscopy, with immunofluorescence microscopy, with electron microscopy to make particular precise diagnosis. Let's discuss minimal change disease, like one of the most frequent causes of nephrotic syndrome. Minimal change disease. It is also called lipoid nephrosis. Why minimal change? Because no changes on light microscopy seen. Have a look on this scheme. In this scheme there is fragment of nephron. It is podocyte present. Then it is with blue color. With orange color it is vessel, fenestrated endothelium cells, and red color it is basement membrane seen. In green color there is juxtaglomerular space. At this moment it is not matter for us. In this scheme I just want to show you that this is normal. This scheme is normal for healthy patients as well as for minimal change disease, because we don't see properly changes on light microscopy. Only epithelium with effaced food processes is recognized. And on next slide you can see scheme. In upper half it is light microscopy, in lower part it is electron microscopy. In left side it is normal, in right side it is minimal change disease. you can see that light microscopy actually looks similarly, no specific changes. But electron microscopy can show us abnormalities. Look on the scheme. Here is food processes in normal situation. You can see them properly. And in right picture, they are not seen because they are flattened, effaced. There is the problem. This is structural damage which develops in minimal change disease. Pathogenesis. In pathogenesis, there is different, it may be primary and secondary minimal change disease. Primary, it is idiopathic. Secondary, due to another causes. In primary, there is no identifiable extraglomerular disease causes damage of process in podocytes. In secondary, it may be due to infections, non-steroid anti-inflammatory toxic effects, neoplasms with unclear mechanism. Anywhere, they result in abnormal T-cell activation and release of cytokines, sometimes called permeability factors, that are toxic to podocytes. This leads that podocyte food processes efface, become flattened or fuse together. That leads that it is maybe minimal since disease to glomerular seen on light microscopy, but usually it is mostly for electron microscopy. What has happened next? Damage induced by cytokines is not associated with some immune complex deposits and immune reaction, so that immune fluorescence tests are negative in this case. When we have damage of podocyte and it is processed, we have damage to negatively charged food processes, damages the charge barrier of the glomerulars that repels negatively charged molecules. And finally, we can see increased filtration of larger negatively charged molecules like albumin, like another proteins, and the outcome is hypoalbuminemia, proteinuria, which we already discussed before. I will not explain you this kind of scheme because it is already done before in pathogenesis of nephrotic syndrome. Minimal change disease, its incidence about 80% cases in children of 1-8 years, mostly in males compared with females. Etiology, mostly it is unknown etiology. We just suspect factors like non-steroids or some infections. Clinically, it is manifested with nephrotic syndrome. Remember picture of girl with severe edema on the face? It's due to minimal change of disease. And usually it is maybe seen history of urinary tract infection in some patients. It is associated with Hodgkin lymphoma. In laboratory parameters, selective proteinuria may be seen and non-specific changes. And course of this disease is the most favorable because spontaneous remission appears in 25–40% cases. Complete remission with treatment is possible to achieve in 70% cases. And only rare steroid-resistant patients may progress to end stage unfavorable outcome. Mostly it is the most favorable manifestation, the most favorable disease. The next condition, membranous nephropathy. Have a look on scheme. What is abnormalities is here. On this scheme, this is normal situation and this is abnormal. You can see podocyte is preserved and between podocyte and basal membrane there are some dark color deposits. It's deposition of sub-epithelial deposits of some immune complexes. Epithelium is also with effaced food processes and basal membrane is very thickened. On the electronic microscopy, you can see in dark color very thickened basal membrane, basement membrane, and also deposition seen here. At light microscopy, only in early stages there is no some signs, but in late stages they are present. Electron microscopy confirm subepithelial deposits. Pathogenesis. What is happened in membranous nephropathy? First of all, it must be also primary and secondary. Primary is idiopathic, when we can't recognize cause, and secondary when we have some drugs, infections, autoimmune diseases, and so on. What has happened in primary case? We have autoantibodies also. They are made to antigens expressed near or on podocyte surface or planted in the glomerular capillary wall. There are different antibodies, for example, antiphospholipids, A2 receptors antibodies, and so on. Why it is important for us? Because in blood we can also detect these antibodies. They are positive in about 70% cases. These antibodies, IgG antibodies, filters through glomerulus and they accumulate in membrane, between membrane and podocytes. It leads to basement membrane is formed between and around immunocomplex deposit, and in light microscopy, glomerular basement membrane appears thick, and we have signs called spike and dome signs. Pattern appears and it is seen in silver strain. Of course, it is seen in kidney biopsy. We have done kidney biopsy, we got fragment of kidney and try to recognize what is problem. Then, if we're talking about secondary nephropathy, we can see immunofluorescence test is positive because again we have antibodies presence, immunocomplexes deposits in glomerular basement membrane. It gives effacement of podocyte, damage of podocyte, and finally again we can see damage to negatively charged fuse processes, damages the charge barrier on the glomerulars that repels negatively charged molecules like albumin, other proteins, and so on. And again we are coming to situation hypoalbuminemia, proteinuria, and other steps of membranous nephropathy. These steps for development of this disease. Incidence about 60% of adults with nephrotic syndrome, and mean age is 40-60 years. In etiology, mostly idiopathic. Clinically, nephrotic syndrome seen in 80% cases, whereas asymptomatic only in 20% cases. In laboratory analysis, here we can see appearance of microscopic hematuria and non-selective unfavorable proteinuria. About cause, duration, prognosis excellent for children, but for adults it is less favorable because some adults develop end-stage renal disease. In treatment, usually we have effective treatment of this condition. Membranoproliferative glomerulonephritis. What has happened here? This is more serious condition, and let's have a look on scheme. This scheme showing norma, this scheme showing this type of damage of kidney, and you can see subendothelial deposits with thickened basal membrane with interposed mesangial cells process. They are proliferated. For example, in norma, here is green color normal mesangial cells, here is proliferation of mesangial cells. That's why it is called mesangioproliferative type or membrane proliferative type. Basal membrane at all is involved, it is thickened, and on electronic microscopy you can see dark color, it is immune complex deposits. This kind of damage is always associated with damage with immune complex, and in light microscopy we can see signs: mesangial hypercellularity, as I have shown you, presence of immune deposit, I am showing you it, subepithelial space also present there, and also glomerular basement membrane is very thickened and membrane is deformed, changes are present. Incidence, it might be both in children and adults. In etiology, it is usually associated with immune complex, chronic immune complex glomerulonephritis. It may be due to chronic infection, due to systemic lupus erythematosus, cancer, and so on. Anyway, we have immune complex involved. This chain is involved. Clinically, nephrotic syndrome in 50%, and may be seen acute nephritic syndrome, and also it is very frequent history of urinary tract infections in 50%, hypertension, hypertensive type, and renal insufficiency with development of kidney failure is also typical for this. In laboratory analysis, specific signs are hypocomplementemia, decreased level of complement, especially S3 factor, and presence of circulating immune complexes in blood. In course, it is unfavorable course, it is progressive deterioration of renal function, it is usually very short remissions and quick development of end-stage renal diseases within 10 years in 15% of children and 80% of adults. Next subtype is focal segmental glomerular sclerosis. It is sclerosis of individual glomerular segments. That's why it is focal, focality, segmental, and expansion of mesangial matrix, endocapillary hypercellularity, and hyalinosis. Podocytes, of course, are involved and damaged. On the picture, you can see nephrons, and many white color shows scarring. It is glomerular sclerosis development. Of course, this nephron does not working properly, and membranous barrier is not working properly. On the scheme, on electron microscopy, you can see absence of podocyte, its capillary lumen, and just fragment of cells, and many scarring is seen, is present. It is the most unfavorable stage, the most unfavorable disease. It is usually appears in late stage of disease, when most nephrons are scarred and they does not work properly. It is associated with diverse clinical presentations, and usually it is associated with steroid-resistant disease and steroid-resistant nephrotic syndrome. Let's have a look on differential diagnosis of primary forms of nephrotic syndrome. They are typical minimal change disease, focal segmental glomerular sclerosis, and mesangia proliferative type glomerulonephritis. Incidence: minimal change disease is about 85%, mesangial proliferation 10%, focal segmental glomerular sclerosis is about 5%. Age at presentation: minimal change disease 2 to 6 years, mesangial and glomerular sclerosis up to 10 years. Hypertension is not typical for minimal change disease, but mostly typical for focal segmental glomerular sclerosis. Hematuria mostly seen in mesangial and focal segmental glomerular sclerosis. Response to prednisone is good, is present in minimal change disease, whereas for focal segmental glomerular sclerosis it is low, about 20–30%. And likelihood of maintaining renal function is very high for minimal change disease, 95%, whereas for other nosologies it is gradually decreases. And light microscopy, we will not discuss it because I already explained you it before. Let's talk about pathogenesis of diabetic nephropathy. It is typical example of secondary nephrotic syndrome, the most frequent cause of secondary nephrotic syndrome, and main problem here is poor glycemic control, hyperglycemia. Why it is poor, why it is bad for kidneys? It leads to increased glucose uptake, increased glycolysis in glomerular and tubular cells, and increased in formation of free radical production, oxidative stress development. It is pathway which called metabolic pathway. Metabolic exchange abnormalities finally leads to decrease of matrix metalloproteinase production and in decreased regulation, which leads to mesangial matrix damage, expansive, and tubular fibrosis. It is finally manifested with kidney disease. Another pathway, it is hemodynamic. What is hemodynamic pathway? It is activation of renin-angiotensin-aldosterone system, which leads to increased blood pressure, increased kidney function. At this moment, it is initial glomerular hyperfiltration. We can see GFR is high, and also finally this compensatory mechanism can't lead for a long time, and it leads to finally stress, shear stress to glomeruli and pressure-induced damage. We have podocyte loss, podocyte damage, we have increased glomerular basement membrane permeability, again mesangial matrix damage, and again we see albuminuria, protein hypoproteinemia, and all other signs which are typical for nephrotic syndrome. We have also one specific sign, Kimmel-Steele-Wilson lesion, when pink hyaline appear, pink hyaline nodules appear due to accumulation of damaged protein. Finally, we have scarred glomerular, are less able to effectively filter blood, and decreasing in GFR, decreasing in glomerular filtration rate, and diabetic nephropathy formation. Nephropathy complicates about 30% cases of type 1 diabetes mellitus and about 20% in type 2 diabetes mellitus cases. Supportive clues are the presence of normal-sized or enlarged kidneys, evidence proliferative diabetic nephropathy, and blunt urinary sediments. Retinopathy is present in 90% cases in type 1 and 60% patients with type 2 diabetes mellitus. The earliest morphological abnormalities in nephropathy are thickening of glomerular basement membrane, expansion of mesangium, and then scarring, tubular involvement, and so on. Prominent nodular matrix expansion are often found, and it is classical Kimmel-Steele-Wilson lesion. Next situation, it is nephrotoxicity due to some medications. For medications example, I took non-steroid anti-inflammatory drugs, non-NSAIDs toxicity to kidney. Why they are toxicity and how do they act? We remember that they inhibit enzyme called cyclooxygenase, and there is type 1 and type 2. Type 1 is expressed in kidney, type 2 is expressed in both kidney and sites of inflammation. And non-steroids induced nephrotoxicity usually associated with long-term treatment, long usage, independent of dosage. And when we have exhibition of this enzyme, it leads to increased conversion of arachidonic acid to leukotrienes and cause systemic T-cell dysfunction. And this leads to 3 types of outcome. Of them, for us, the most important is this third, when we have activated T cells which infiltrate glomerulars and cause podocyte injury. Epithelial cells attached to the glomerular basement membrane, and 2 types of process may be developed: minimal change disease or membranous nephropathy. Podocyte effacement allows for serum protein to cross the glomerulars into the tubular lumen, and we can see again manifestations: proteinuria, hypoalbuminemia, edema, and so on. This way how medications act toxicity, making toxicity for the kidneys. Differential diagnosis of nephrotic syndrome. Nephrotic syndrome is frequently confused with nephritic syndrome, so that I think it will be useful to differentiate it. So, nephrotic syndrome, main characteristic of nephrotic syndrome is low serum albumin, proteinuria, edema, dyslipidemia, hypercoagulability, and reduced immunity also. For nephritic syndrome, main characteristics are hematuria, hypertension, mild proteinuria, mild edema, and temporary oliguria and uremia. Symptoms. What differences in symptoms? For nephrotic syndrome, main symptoms are edema, peripheral edema, facial edema, frothy urine, fatigue, and recurrent infections. For nephritic syndrome, symptoms are hematuria, mild edema, oliguria, signs of uremia like fatigue, pruritus, nausea, and so on. Proteinuria is more typical for nephrotic syndrome. It may be seen in nephritic, but number of protein lost is not so high. Hematuria, it is typical for nephritic syndrome. It may be present, but usually it is absent for nephrotic syndrome. RBC cast, it is present in nephritic syndrome, but absent in nephrotic. And then causes, the most typical causes for this is nephrotic syndrome, minimal change disease, membranous nephropathia, focal segmental glomerulosclerosis. They are typical causes for primary situations. For secondary, we already said about diabetic nephropathia. And for nephritic syndrome, causes are immunoglobulin A nephropathia, post-streptococcal glomerulonephritis, rapidly progressive glomerulonephritis, and so on. Causes are also different, we can see this. Complications. They are more regular in severe nephrotic forms, and complications are following. New infections, first of all, bacterial, viral, fungal, because immunity is decreased. Hypovolemic nephrotic crisis or nephrotic shock, acute kidney, acute renal failure, swelling of the brain, retina, vascular complications, and allergic manifestations. Have a look what is nephrotic crisis. It is sudden deterioration in condition of patient with severe hypoproteinemia, less than 35 gram per liter, hypoalbuminemia. It is associated with hypovolemia, decreased blood pressure, hypotension, arterial hypotension, and possibility of death. It is manifested with anorexia, nausea, and vomiting. Abdominal signs appears, and then intense abdominal pain appear, migratory erythema erysipelas on skin appear, and most often it is abdomen area of the skin is involved, and anterior surface of thigh and legs. Then cerebral edema. It is usually occurs in like one sign of severe general edema, anasarca. It is manifested by lethargy, patient is coming to coma, it can turn into cerebral coma finally, and in addition pronounced edematous syndrome, retinal edema is also often detected. It is reversible with increase in concentration of albumin of the blood serum. What vascular complications typical? They are due to hypercoagulability and thrombosis. For example, peripheral phlebothrombosis, deep vein thrombosis, pulmonary embolism, renal artery thrombosis, and so on. Then, causes of death. Why a patient with nephrotic syndrome could die? First of all, it's maybe due to activity of underlying disease of nephropathia. Then due to hypovolemic shock, kidney crisis. Then maybe infection complications. Patient may develop quickly pneumonia, pleural empyema, sepsis, and so on. Then, if long duration of disease due to kidney failure, patient can die due to kidney failure. Then he can die due to complications like thrombosis and other vascular complications. And in some cases, it may be iatrogenic causes like agranulocytosis, bleeding from GIT, progressive hepatitis, and so on. So depend on additional comorbid diseases. Treatment. For treatment, we must follow following goals. Is achievement of full and partial remission, full if possible, if impossible partial remission for kidney disease, then elimination of symptoms and complications, and slowing down the progression of chronic kidney disease and delaying its terminal stage when dialysis and kidney transplant is required. Treatment tactics cover three possible directions. It's disease-specified therapy or pathogenic therapy, it is symptomatic therapy, and therapy of complications and comorbid conditions, and so on. In treatment approaches, we also pay attention that there are non-pharmacological methods of treatment, pharmacological methods of treatment, and some invasive surgical methods of treatment. Among non-pharmacological methods, we pay attention to diet and activity of patient. The diet in patients with nephrotic syndrome should provide adequate energy, calorie intake, adequate protein, but we don't indicate high protein diet. It is not help, it will not effective for patient. Recommended protein level you can see about up to 1 gram per kg per day. A diet with no salt which will be effective and will help to limit fluid overload. Fluid restriction is not required, and inactivity, ongoing activity rather than bed rest will reduce risk of blood clotting. Hypomobility is not recommended for this patient. Let's talk about pharmacological treatment. Disease-specific therapy, pathogenic treatment. Pathogenic therapy, it differs depend on morphological variant of glomerulonephritis. Therefore, it is eligible only after a kidney biopsy. And first of all, we verify morphological diagnosis, and then we continue this treatment. We make treatment. What is this disease-specific therapy? For minimal change disease, it is mostly peroral glucocorticosteroids, prednisone, prescribed for reducing urinary protein level at the initial treatment, for preventing the acute decline of renal function. If there is no effect, rituximab can be used. If we're talking about membranous nephropathy, we need combination of glucocorticosteroids and immunosuppressive medications. Corticosteroids, you can see prednisone 0.5 mg per kg per day, or methylprednisolone can be used, and immunosuppressant medications like cyclophosphamide or cyclosporin. These medications, why we use immunosuppression? Because we have immune mechanism in pathogenesis of this disease, and usually we start treatment only with corticosteroids without immunosuppression for the first 6 months, but it's possible only in patient with low risk for progression, having normal creatinine level and so on. And if patient have some signs of kidney failure, high risk of quick progression of disease and so on, we must use and start together both immunosuppressive medications and corticosteroids. The duration of treatment may be very long. It is not 1 month, it may be 2 years and more. If there is no effect, rituximab can be used. Next, focal segmental glomerular sclerosis. In this situation, we don't use actually some immune therapy, and steroid therapy for reducing urinary protein level and preventing decline of renal function may be used at the initial treatment. But usually, actually, it's end-stage situation, which when take glucocorticoids or immunosuppressants, it's too late to do this. So that it is unfavorable for treatment situation, and usually we don't use immunosuppressants at all. Lupus nephritis. For this situation, prednisone and cyclophosphamides are useful. Secondary amyloidosis. We must use anti-inflammatory therapy of primary disease. As amyloidosis is usually caused by rheumatoid arthritis, we must intensify treatment of rheumatoid arthritis. Usually it is methotrexate plus folic acid, usage of prednisone and so on. If we're talking about diabetic nephropathy, the treatment involves aggressive glucose control and aggressive blood pressure control with usage of ACE inhibitors, angiotensin converting enzymes, and ARBs, angiotensin receptor blockers, or both. This is disease-specific therapy, and result for treatment may be different. If we see response of patients, that means treatment is good. Usually it's response to prednisone when urine albumin nil or trace for 3 consecutive early morning specimens. It may be steroid resistance when our patient is non-responder. It is when we treat patient but there is absence of remission despite of therapy. And non-responder may be early and may be late. Initial early non-responder, it is when we have no response during initial 8 weeks of therapy. Late non-responder, it is when initial steroid responder fails to respond for 4 weeks treatment in relapse. And finally, we can see situations steroid dependence. It is responder who relapse while steroid therapy is being tapered or within 14 days for its discontinuation. What does it mean? We start treatment with glucocorticosteroids, we're waiting for result which is improving condition, but at this moment patient give exacerbation, relapse. This means steroid dependent situation. For checking effectivity of treatment, we must consider remissions and relapses. In responders, course of disease usually has alternation of remissions and relapses. The therapeutic evaluation is done by the amount of urine protein at first and 6 months after initiation of treatment. We can achieve the most favorable situation when complete remission is achieved, when urine protein is decreases and achieve level less than 0.3 gram per day. We can achieve incomplete remission when urine protein become less but not so good like in first situation. It ranges between 0.3–3.5 gram per day. We can achieve relapse when urine albumin or protein is high and even more increased for 3 consecutive early morning specimens after having been in remission previously. And if we're talking about relapses, frequent relapse is when patient has 2 or more relapses in 6 months period or more than 3 relapses in 1 year. How to treat relapse? In 50–75% relapses present, they appear. And how do we treat it? We increase dose of prednisone, we prescribe it about 60–80 mg per day for 4 weeks and then gradually decrease it. And then we also, with frequent relapses or steroid dependent form, we use low dose of prednisone with immunosuppressants like cyclophosphamide, like mycophenolic acid, mycophenolic mofetil or cyclosporin. Different, we choose precise particular immunosuppressive medication and we decrease dose of glucocorticoids. In case of steroid resistance, second biopsy is recommended because maybe it is we treat something another. We must check maybe transformation to focal segmental glomerulosclerosis presence and we must change our treatment tactic. This was only pathogenic therapy of specific cause. Next, we must use nephroprotective therapy. It is also very important in every situation of nephrotic syndrome. Despite ongoing immunosuppressive therapy, nephroprotective agents are of importance, and there are 2 classes of medications. They are antihypertensive drugs, ACE inhibitors, and angiotensin receptor blockers. They block renin-angiotensin-aldosterone system, and they have proven effect for cardiovascular system and for kidney urinary system. If our blood pressure is not at a goal after 4 weeks treatment, we can increase dose. If again it is not in a goal, we can use additionally calcium channel blockers like diltiazem, verapamil. Verapamil is especially recommended for patients having highly proteinuria. In the presence of persistent glomerular hematuria without proteinuria, we can use nephroprotective therapy. It is highly indicated. Then, symptomatic treatment. To control edema, we must use diuretics. For example, furosemide 40 mg per day, torocemide up to 20 mg per day. If creatinine is not so high, and we can also use chloraltolidone, 2 groups of medications we can use in diuretics. It may be used daily courses for decreasing edema. Then, to control proteinuria, ACE inhibitors, ARBs and calcium channel blockers. Information from previous slide. To control hyperlipidemia, if present, we prescribe statins. We must also control cardiovascular risk factors and target blood pressure. To avoid toxic effect of medication, we must minimize or avoid these medications like non-steroid anti-inflammatory drugs, like intravenous contrast, antibiotics, because these agents can potentially induce acute kidney injury, and acute kidney injury, of course, exacerbate underlying kidney disease. To control blood pressure, we use all medications which was said before. First of all, ACE inhibitors and angiotensin receptor blockers, and besides we can use beta blockers and aldosterone antagonists. Beta blocker therapy, it's not effective for hypertensive therapy, but it is recommended for patients having coronary heart diseases with myocardial infarctions, angina, arrhythmia, and so on. What about aldosterone antagonist therapy? The medication used is spironolactone. It's also potassium-sparing diuretics. It's affect renin-angiotensin aldosterone system, and that's why it is useful. It is proven effect, and we can use it even in small dose, starting from 25 milligram per day. We must pay attention that spironolactone for long usage can cause hyperkalemia, and we must check up potassium regularly. Next, our patient has hypocalcemia. If so, we must give him calcium carbonate. Its infusion may be done, it may be in medications, and it is usually long-term courses, especially if we give patient prednisone for long time. If patient has infection complications, we give antibiotics. For thromboembolic complications, we use low molecular weight heparins subcutaneously, courses, and achieving disappear when thromboembolic complication will disappear. If hypovolemic shock or kidney crisis develops, we must restore by urgent infusion of normal solutions and symptomatic treatment. Now let's conclude. So, nephrotic syndrome. First of all, it is syndrome which can be caused by many diseases. The most important sign is high proteinuria, edema-like manifestation, hyperlipidemia, and thrombosis. We must pay attention to urine analysis because it is probably one of the most informative methods for prescribing this diagnosis syndrome. Then we must pay attention to what possible cause of nephrotic syndrome, and they are different, and sometimes it is required to do renal biopsy to give particular diagnosis. And finally, we start treatment which depend on particular cause, but generally it has symptomatic directions like diuretics in edema, nephroprotective, specific therapy for kidney, and treatment of complications if they are present. Thank you so much for watching. That's all for today. Have a good day. Goodbye.